Let's talk about something that is incredibly common that you are going to see frequently, and these are leg and foot ulcers. Now, guys, you may think, well, this is not terribly interesting, but it's common. And you got to realize, as a physician, a significant proportion of the patients you will see will be common things. And that's why, people ask me, why did I go into medicine? I went into medicine for two reasons. I like science and I like people. And even though you may think, oh my God, another leg and foot ulcer, so common, but what makes it interesting is your relationship with the patient. So just to let you know, even though you're seeing common things, it's always interesting because you're meeting different types of people. And once again, as I told you in another video that we've done, never, ever, ever, ever make a judgment, meaning people may have different approaches, different thoughts, different opinions, things like that. As a physician, you never, ever, ever make a judgment. And I think, as I once told you, perhaps when people would ask me, patients would ask me, well, Dr. Hill, are you a Democrat or a Republican? I always answer, I'm a Gemini, astrologic sign, which I am a Gemini and stuff like that. Again, you never, ever make a value judgment or get into a discussion about something which you won't be able to get out of. Always remember that, okay? All right, let's talk about leg ulcers. There are basically three types of leg ulcers. The first type we're going to talk about is called an arterial foot ulcer. An arterial foot ulcer. And arterial foot ulcers occur at the tips of the toes. And it is due to arteriosclerotic disease. It's due to arteriosclerotic disease. So arterial foot ulcers occur at the tips of the toes. And the treatment obviously is evaluation of the arterial system and revascularization. So arterial foot ulcers commonly seen tips of the toes. The second type of foot ulcer is really, really common, and that is a venous stasis ulcer. A venous stasis ulcer. And you're going to be asked on the test, what is the cause of a venous stasis ulcer? It is incompetent venous valves. Incompetent venous valves. You're going to say, oh, maybe it's varicose veins or stuff like that. That's true. But the real reason is incompetent venous valves, because remember, the valves in your venous system, in your saphenous system, are one-way valves. And what happens is when you have inflammation, even mild inflammation, those valves deteriorate. And the number one question to ask you that you need to know is, do those valves regenerate? No. So you got a column of blood that when you stand up is going to turn into varicose veins because of venous hypertension. So venous stasis ulcers are due to incompetent venous valves, which causes venous hypertension due to hydrostatic changes, meaning gravity. Very simply, very simply. Now, test question, life question, where's the most common location of a venous stasis ulcer? Where do you find your greater saphenous vein? Medial malleolus. Medial malleolus. Can it occur other places? Sure. But by far the most common is the medial malleolar area where the greater saphenous vein is. Everyone has varicose veins to an extent. And in part, it's familial, meaning it's not like blue eyes or brown eyes or things like that. But sometimes you'll meet patients who have bad varicose veins, venous insufficiency, at 20s and 30s, whereas other people don't get them until they're 60, 70, 80, and some people don't get them at all. It's familial. It's not Mendelian genetics, but it's familial. And of course, it's related to your occupation. If you're on your feet all the time, the chance that you'll get them are increased. Now, listen carefully. The treatment of venous stasis ulcers is gigantic. I mean, there's so many different options. Elevation of the extremity, debridement, compression devices, surgery, sclerotherapy, etc., etc., etc. And they're not going to test you specifically on each one of these, but they are going to test you on this concept. So listen carefully. The most common reason that someone comes into the emergency room for a venous stasis ulcer is not because they have a venous stasis ulcer. It's because they have an infected venous stasis ulcer. That's so important. I'm going to say it again. Most common reason people come in to the emergency room with a venous stasis ulcer is not because they have a venous stasis ulcer. It's because they have an infected venous stasis ulcer. Very, very important. And they come in septic. Oh my God, you will see this all the time. I get consults all the time. Patient comes in through the emergency room, has sepsis, and they've got an infected venous stasis ulcer. Now listen carefully. I told you about all the different treatment for a venous stasis ulcer in of itself. Elevation, dressing changes, debridement, sclerotherapy, surgery, etc., 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 etc. Okay? But the reason that they're in the house, and remember the term house is used for hospital, okay? The reason they're in the house is because of infection, sepsis. And therefore the treatment of that would of course be intravenous antibiotics and surgical debridement, getting rid of all the dead tissue. So I'm going to teach you a very important concept. Guys, you will not be able, no matter how skilled you are, to heal all venous stasis ulcers. And that's not necessarily your goal in the hospital. Your goal in the hospital is to change that venous stasis ulcer from infected to non-infected. The reason I tell you that is a lot of family members, and understand, don't ever expect a family member to know everything that you know. You're a doctor, okay? And you'll say, well, I think your mom and dad are ready to go home, back to the nursing home. And they'll say, well, Dr. Hill, the venous stasis ulcer is still there. And you have to explain to them that it's not always I say that again. It's not always possible to actually heal a venous stasis ulcer back to normal skin. But the point is, the reason the patient usually comes into the emergency room is because of an infected venous stasis ulcer. And what you're doing is getting rid of the infection. Yes, you are doing things to hopefully heal the venous stasis ulcer, but I just want to tell you something. When you've been in practice as long as I have, 38 years, yeah, a lot of these venous stasis ulcers, you can't heal them, but you keep them from getting infected. So I hope you understand it. A very important point. All right. The next type of ulcer that we're going to talk about is a real common ulcer, and that is a diabetic foot ulcer. A diabetic foot ulcer. Why do diabetics get foot ulcers? One reason: neuropathy. Neuropathy. Guys, if you had a stone in your shoe, how long would it take you to notice it and take out that stone? Seconds. A diabetic has neuropathy. And even though they have compromise of their vascular system as well, it's the neuropathy that makes them not feel it. And that's why they get diabetic foot ulcers. Test question, life question. The most common location of a diabetic foot ulcer is the first metatarsal phalangeal joint. The first metatarsal phalangeal joint. Why are athletes so concerned with the first metatarsal phalangeal joint? Because an athlete puts most of their weight on the first metatarsal phalangeal joint. So that is why it's the most common location for diabetic foot ulcer, first metatarsal phalangeal joint. The second most common location for a diabetic foot ulcer is the heel, calcaneus. So the first is the first metatarsal phalangeal joint. Second is the heel, calcaneus. Now, when you have a diabetic foot ulcer, the first thing you have to do is rule out two things. Follow me. This is very important. Number one, osteomyelitis. Osteomyelitis. And what is the best test for osteomyelitis? An MRI. And you don't have to get it emergently, meaning in the middle of the night. You get an MRI the next day. But the other test that you get is a plain film of the foot. Now you're asking me, why would you possibly get a plain film of the foot? When I told you just before, I said that plain films are the worst imaging study for osteomyelitis, and that's true. But your plain film of the foot is not looking for osteomyelitis. It's looking, test question, life question, for a foreign body. For a foreign body. That's what you're looking for the plain film, because, guys, sure, you've got an ulcer there, and sure, it is due to a foreign body of some sort that's causing pressure. Well, you got to make sure that that foreign body isn't still there. Very important point. So the two tests you always get: MRI to rule out osteomyelitis the next day, and you get a plain film of the foot, and someone's going to ask you why, to look for a foreign body, because they could have a needle in there, they could have a piece of metal. I've seen everything embedded in the ulcer, and obviously you got to take it out. Now, the key for surgery initially for an infected diabetic foot ulcer is obviously debridement. Do you need antibiotics? Yes, if you have a infection, a systemic infection, a cellulitis, yes. But if you've got dead tissue there, which you likely do, necrotic tissue must be removed, debridement, okay? Just to let you know that I want you to understand that so many of these diabetic foot ulcers, you know, when they have osteomyelitis, you treat them with 6 weeks of antibiotics. And I told you that osteomyelitis is not an easily treated infection. So many of these people with diabetic foot ulcers, as you know, and you know what I'm going to say, end up with amputations. And so I just want you, don't be terribly optimistic that when you have a patient with diabetic foot ulcer with osteomyelitis that you're going to cure it. And many of the times you need to do an amputation, and it's well known. And so just be realistic and recognize that osteomyelitis is a bad disease in of itself, a bad infection in of itself. And when you've got a diabetic person who one of their difficulties is their vascular supply, as you know, it just makes things worse. So I just want you to be realistic, and that's very important. All right. Now let's talk about a patient who has had any kind of foot ulcer for a long period of time. I don't mean months, guys. I mean years and years and years. And let's say it wasn't treated very well. And I mean years and years and years. They could even have a burn. They could even have a scar. And they come in and they have white mounded tissue. White mounded tissue around their wound. Guys, that is a squamous cell cancer. The eponym for that is a Marjolain's ulcer, named after Dr. Marjolain. You need to know that for the test. A Marjolain's ulcer. It's a squamous cell cancer. And obviously you got to treat that. That's usually a bad cancer. But I want to make it very clear that this is not after months, and it's not after 1, 2, 3 years. It's after decades. Chronic irritation of a wound will cause malignant transformation. That's so important. I'm going to say it again. Chronic irritation of a wound will cause malignant transformation over many, many years. I'll tell you a story. I have had a number of patients who have what's called Picker's syndrome, not named after Dr. Picker, but they're called Picker syndrome because they pick things. They pick things. Now, I'm not talking, we all pick things, okay? We're humans. I'm talking about people who will, and it's a psychiatric disorder, who will pick things where they will destroy their epidermis and dermis. I mean, they will come in with ulcers. Guys, I don't know if you've ever seen this, but someday you will see someone with what's called Picker syndrome. It's a psychiatric disturbance. And you talk to the patients and they're real nice and stuff, and you say to them, and you always have to debride them. You always have to debride them because they have dead tissue. I mean, from their fingernails. I mean, and you can always tell if they're righty or lefty. Because if they're right-handed, it's always mostly on the left side of their body, you know, because they do that. And the patients are usually very nice, and you say, you know, I know you like to do this, but you're going to get into trouble. And they always say, you know, they say, I understand, Dr. Hill. And I said, please don't do this anymore. And they usually say, okay, I won't. And then they come in 2 weeks later with an infection or another ulcer and stuff like that. And I have had some of these patients end up because I've been in practice 38 years, so we're talking about a long, long period of time, with marginal ulcer, squamous cell cancer. So just know that a chronic ulcer, no matter what the etiology is not a good thing. All right? Okay. Let's continue and talk about foot pain. And one of the things we're going to talk about is plantar fasciitis. Common? Yes. Do we know definitively what causes plantar fasciitis? No. If you want to win the Nobel Prize, find out. The most important thing about plantar fasciitis, which is very painful, and I'll bet you some of you young colleagues have even had it yourself, as well as seen patients who have had it. It's self-limiting, meaning it goes away on its own. Sometimes it takes 6 months, sometimes a year, sometimes even a year and a half. But it's very painful. And you treat it symptomatically, NSAIDs, pain relievers, a number of different symptomatic treatments. But there's one thing that you're going to be tested on and you need to know. There is no definitive evidence that calcaneal bone spurs cause plantar fasciitis. Why do I say that? You will have some patients who will get an x-ray of their heel who have plantar fasciitis, and they will have a bone spur. And there may be a surgeon who says, hey, I'm going to cut out that bone spur. That bone spur may be causing your plantar fasciitis. And they cut out the bone spur, and a month later, the plantar fasciitis goes away. Guys, there's no definitive evidence that the bone spur caused the plantar fasciitis. And the plantar fasciitis would have likely gone away by itself with or without surgery. So test question and life question. There's no definitive evidence that bone spurs in and of themselves cause plantar fasciitis, meaning not at your age, but at my age. If I took x-rays of every person my age who just took pictures of their calcaneal bones, a fair number would have bone spurs. Does that same number have plantar fasciitis? No. So there's no definitive evidence. That's a test question and a life question. Just remember that. All right. Next, one of the most frustrating things I'm going to talk about, and that is a patient comes in and they have unbelievable pain in between their toes. And I look at their shoes, and their shoes are like this, pointed like that, and perhaps high heels as well. And what these patients have is something called a Morton's neuroma. A Morton's neuroma, which is a benign tumor of the digital nerve. And it is caused by pressure from the shoes. This is a man-made disease. Just like carpal tunnel, cavemen did not wear shoes like that. Now, when someone comes in with a Morton's neuroma, it's painful. It's not malignant, but it's painful. And it's kind of a challenge in terms of your interpersonal relations with the patient. Meaning, what you have to do is you have to say, well, what kind of shoes are you wearing? And they'll, show you, and they'll say, and you say, well, maybe you should wear flip-flops or, shoes that are more comfortable. And then the patient, you have a good relationship with the patient will say to you, well, Dr. Hill, don't you like my shoes? Say, oh, I love your shoes. Your shoes are great. But they may be causing, this problem. And understand this is a time when you have to have good interpersonal relationships, because you have to finally say to the patient in a gentle way, well, you got two choices: to wear flip-flops or shoes that, don't squish your toes and things like that, or surgically, I have to take out that nerve, that neuroma. And guys, there are a fair percentage of my patients bright people who will look me directly in the eye and say, Dr. Hill, do the surgery. Guys, you have to understand that you can't change everyone's mind. And I personally, as a man, I ask my wife this all the time. I said, how could you wear shoes that are uncomfortable? She says, because they look great. And I said, yes, they do look great, but they're uncomfortable. I mean, again, you never make a judgment. This is a frustrating thing as a practitioner, as a surgeon, because I see this commonly. And again, you never make a judgment, but it's a man-made disease, a Morton's neuroma. And it is due to absolutely pressure from the shoes themselves. I mean, so it's a tough thing to deal with, because patients are people, and you can't demand things, you can't force them to do things. We're not dealing with a malignant process, so it's not like you're going to die from this. So you have to use good interpersonal skills, which is commonly referred to in the past as bedside manner, which I believe very strongly in. Okay. Let's continue.